I'm Dr. Girish Warrier, pediatric cardiothoracic surgeon at Aster MIMS Hospital, Calicut, from Kerala. I am a pediatric cardiothoracic surgeon and I deal with children with heart diseases, both blue baby syndrome and also patients having non-blue, that is acyanotic heart disease. I have been involved with children since 2002 and I've had extensive experience with these children. Today I thought we will talk about blue baby syndrome, which is also known as cyanotic congenital heart disease. Of course, there are various causes for blue baby syndrome, but I'm more interested in children with heart disease. The blue color or the blue baby syndrome happens when the impure blood gets mixed with the pure blood, and the level of mixing would decide on how blue the baby is going to be. To sort of summarize, what happens is that the blood from the body comes to the heart, and from the heart it goes to the lungs. From the lungs it comes back to the left side of the heart and then gets pumped out. Now, if there is any obstruction to this level, to this shunting, it will cause severe effects on the baby's heart and the body. Now, in blue baby syndrome, what happens is the impure blood which is coming from the body does not find it easy to go to the lungs to get purified. When that happens, the mixing of the impure and the pure blood happens through a hole either in the upper chamber or the lower chamber. Upper chamber would be an ASD, lower chamber would be VSD. In the most common condition that we have blue baby syndrome is the Tetralogy of Fallot, and we thought we will talk briefly about this. Tetralogy of Fallot, as the name signifies, has 4 different conditions. That is, it has a large ventricular septal defect, that is a hole in the lower chamber of the heart. It also has significant right ventricular hypertrophy, that is thickening of the muscles of the right ventricle. It has obstruction to the outflow path, causing pulmonary stenosis, and it also has deviation of the septum, of the ventricular septum. So these 4 conditions comprises the Tetralogy of Fallot. Now, the more the severe the obstruction is, more blue is the baby. This is because the blood is not able to get to the lungs to get purified, and when that happens, the impure blood and the pure blood mix, and it goes to the body as a mixture of the blood. And the more the obstruction, as I said, more blue will be the baby. Now, these children will present generally at the age of around 6 weeks to 8 weeks, where the neonatal circulation is sort of being withdrawn and the child gets to the normal circulation. So at this time, what happens is that the pressures in the lungs would be lower and pressures in the body would be higher. Normally, in these cases, if there's large VSD without an obstruction, it will cause more blood go to the lungs. But in these children with Tetralogy of Fallot, because of the obstruction, that doesn't happen, and the impure blood goes to the body. When this happens, the oxygen level in the blood goes very low, and children get very sick because the oxygen is not being delivered to the body, to different parts of the body like the brain, the kidneys, the liver, etc. Especially when you have a low oxygen level in the brain, you will have irritable child with significant lethargy. They will have something called spells, that is cyanotic spells, in which the child cries for some time and then becomes very blue and then sort of becomes very sleepy and sedated. Now, when this happens, the child has to get revived by giving medicines or oxygen or sedating the baby, so that the child's oxygenation improves over a period of time. This is a very significant, very severe condition which needs urgent surgery to correct the problem. Now, these children are diagnosed, as I said, at around 6 to 8 weeks, where we find that the child is getting bluer and bluer and may or may not have spells. Now, these children will come to the OP with irritability, with blue color of the fingers and toes, of the tongue, of the mouth, etc. And they will be a little lethargic. We investigate these babies by doing mostly a physical examination, which will obviously show murmur, and also an echocardiogram. Echocardiogram actually helps us to reveal the exact problems that's happening inside the heart, how big the VSD is, how severe the obstruction is going to be, and what the pulmonary artery branches are looking like. Now, these are the things that will be addressed to when we do operate on these babies. These children have to have a surgery, and without surgery, they cannot survive very long. So, there's no medical treatment for Tetralogy of Fallot. Now, what we do in surgery is we can either have a palliative surgery, that is, try to improve the blood flow to the lungs temporarily by putting a shunt or putting a stent in the PDA, which will increase the blood flow to the lungs for the time being. But as the child grows older, the child needs to have a closure of the hole as well as relief of the obstruction to the right ventricular outflow. So that's the definitive surgery. That is, we have to close the hole and we have to remove the obstruction to the lungs of the blood flow to the lungs. And this will need open heart surgery, which is quite significant. That it has to be addressed to the chest. We have to open the sternum, the breastbone, and then reach the heart. We have to put the baby on a machine called the cardiopulmonary bypass machine or the heart lung machine, which will temporarily act as both heart and the lungs during the procedure. Once we do that, we can stop the heart and do the operation. We'll close the hole, we'll make the outflow very clear, that is, there's no obstruction to the outflow, and then we will take the machine off from the baby, and that will make the baby almost like a normal child. Now, some of these children have something called pulmonary valve stenosis also, which will need the valve to be cut and enlarged with the patch. So those children might have to have a valve replacement in the future, maybe 10, 15, 20 years later. So these children can function as like other children until they go for a replacement of the pulmonary valve at a later date. The prognosis is very excellent in these patients, and they do very well. They can perform well in school, they can run around, they can play around as normal, and they can achieve a reasonably good life, almost equal to the normal children. These children have to be, however, be followed up over several periods of time, because several years of life, because the effects of the pulmonary valve leak or any obstruction which is developing later on has to be diagnosed very early so that we can take care of them. This is something that we do in Tetralogy of Fallot. Thank you very much.